Today, what I'm going to do is just show you some cases. Some of them are easy, while some of them are slightly more difficult, and how we have approached these cases. And some of them will be repetition from yesterday, just to re-emphasize the importance of the findings. So, 39-year-old gentleman, right-sided weakness. What's the abnormality? Yes, the left dense MCA sign, and you can see that the patient has come a little early on. We can see slight effacement of the parenchyma, like as compared to the contralateral side, there is some effacement, and the gray by differentiation is lost. So looking at that, we know that there is a fairly large MCA territory infarct. MR imaging was done a day later, and we can see again a fairly large infarct, and there's effacement of the left lateral ventricle and early midline shift. So what would be the next line of management? Yeah, so most likely this patient will go for decompressive craniectomy. Another case, patient with left MCA infarct. Now, patient first came and a CT scan was done. We can see that it's so difficult to identify the acute infarct in the CT study, but often the main role of CT study in these infarcts is not to identify the infarct, but to exclude acute hemorrhage or to exclude the mimics. So once we exclude mimics and acute hemorrhage, then actually the patients can be thrombolized. So in this, we can see the T2 flare. In CMC, we often do a MR-based acute stroke protocol, which includes T2 flare imaging, diffusion, SWI to look for blood, and angiogram. So this is a T2 flare sequence, which looks fairly unremarkable, and then we can see that there's a fairly large infarct in the left MCA. So here, it's important to note that normal appearance of T2 flare and the diffusion. So this is called the T2 flare mismatch sign. So basically what it says is, what it means is the patient has come quite early on. So patient may be still in the window period. Basically the edema has not really established on the T2 flare. If the T2 flare also is abnormal, that means there is a match. That means some time has gone for the infarct. Another case, 21-year-old gentleman, case of SLE with acute onset right-sided weakness. Anything obvious? So there's a very large hypodense area. So what do you think it is? So our first thought would be whether this is an acute infarct. If we just go by CT, sometimes we might thrombolize these patients. But if you look carefully, there is some hypodensity in the contralateral side as well. So that is a little unusual for an infarct to do, and especially if the patient is just 21 years old. So in this MR study was done, and as you can see on the T2 weighted sequences, we can see multiple lesions involving bilateral basal ganglia, a lot of edema in the adjacent to them. There is a lot of blooming in the SWI sequence, suggestive of microhemorrhages, and there's a lot of diffusion restriction as well. So it's looking like there's some kind of an abscesses. Little bit of post-contrast enhancement. Patients who are immunosuppressed, we usually don't expect a lot of enhancement in them. So usually enhancement will be less in these patients. So now this is it's a little difficult case in the sense that we can see some abscess, but we are not sure. We'll not be able to tell what exactly the organism is. It could be bacterial, it could be fungal. So do we treat the patient both for bacterial and fungal? It's difficult. Now there is no involvement of the meninges as so the CSF actually not recommended, but even if CSF is done, may not actually help here. So the plan was, we have actually seen a couple of cases, patients immunosuppressed and coming with abscesses. Many of them have ended up being nocardia. So the plan was treat the patient as nocardia. If the patient responds, good. If the patient doesn't respond, go for biopsy. So this is a follow-up imaging for this patient. The initial study showing a lot of abscesses. Then within 2 weeks, we can see significant regression of the edema. The lesions have become smaller in size. And then we have follow-up at 2 months and 1 year. So at 1 year, we can just see some areas of gliosis within the basal ganglia. So it's presumed to be a nocardial infection. Another patient, 56-year-old male with headache. We have seen a similar case yesterday. What do you think is the diagnosis here? So there's a large bleed in the left frontal lobe. And what would be the cause? So yeah, so if you see the superior sagittal sinus, there is a lot of density over there. So it's hyperdense. So it's an acute thrombosis of the superior sagittal sinus with a fairly large venous infarct. This is the imaging done after 5 days. We can again see a lot of edema involving the left frontal lobe. Some midline shift has occurred, and the venogram demonstrates filling defect within the superior sagittal sinus. 25-year-old lady with headache, vomiting, suspected CVT, known rheumatic valvular heart disease, post-mitral valve replacement on anticoagulation. So a lady with headache on anticoagulation. Anything that's standing out? So there's something on the left side, but we are not sure, isn't it? So if you see the right side and the left side, the gray white differentiation. So here there seems to be as if there's a lot of gray matter over here, and that is causing some effacement of the underlying parenchyma and some little bit of effacement of the left lateral ventricle, a little bit of midline shift towards the contralateral side. So these are the cases where, especially that the patient is on anticoagulation, we should consider subdural hemorrhage. Now, we have often seen acute and chronic subdural hemorrhages. So acute will be quite bright. It will look white in color. But as the time goes by, it starts becoming darker and darker and darker, and eventually it will look like a CSF, so it will be quite dark. But as it becomes darker from its being very hyper dense initially, it will be in a phase where it will almost look like the brain tissue, its density. So this will be that phase where it has, so it's not too acute, but it's not chronic as well. So it's somewhere in between where its density is similar to the adjacent parenchyma. That is one. Second thing is the hemoglobin of the patient. Some patients be quite anemic. So if the hemoglobin is low, the acute blood will not look bright. So it will be little darker. So that is another thing. So always when you're thinking of bleed, keep an eye on the hemoglobin as well. So this is MR scan done on the same day, and you can see a fairly large subdural hemorrhage on the same side. So this is how an acute or chronic subdural hemorrhage would look like. The brighter part is the acute blood, while the more superior part is a little darker. So that is a chronic component of the subdural hemorrhage. This is a 60-year-old male with acute confusion. Now we can see that there's a lot of edema involving the left parietal lobe and extending into the left temporal lobe. So what do you think? Acute confusion, what would be the underlying cause? We will have to have some differentials. So is this an infarct? Well, density-wise is possible, but look at the regions are involved, part of the temporal lobe, part of the parietal lobe, part of the occipital lobe. So the arterial territories are overlapping. So that is the point against an acute infarct. Unless there is a fetal PCA and some compromise of ICA and the fetal PCA, then maybe partially we can explain, otherwise we can't explain. Can it be a CVT? We are not seeing density along the superior sagittal sinus, plus there is no acute blood in the underlying parenchyma. Can it be a tumor? So we are not really seeing a lot of tissue expansion, what we would normally expect with a tumor. So there is some kind of a weird edema, but it's really difficult to say what it is. So we need to further evaluate with an MR scan. So on the T2 weighted sequence, we can see that, again, a lot of edema in the left temporal lobe and occipital lobe. There is no diffusion, so it's not an acute infarct. The SWI is quite remarkable, in which we can see multiple foci of blooming, predominantly in the cortical and subcortical region, suggestive of microhemorrhages. And then there are some other smaller foci of blooming in the contralateral side as well. So multiple microhemorrhages. These are not central in location, what we would normally expect with hypertensive patients, but these are quite peripheral, so along the margins. So once we see this, we should think in terms of cerebral amyloid angiopathy. Now, this is a subtype of cerebral amyloid angiopathy in which there is a lot of edema. So this is called the inflammatory cerebral amyloid angiopathy. So this patient was started on steroids, and this is a follow-up after 3 months where the edema has become less, and follow-up after 2 years where we are just seeing some kind of underlying gliosis. SWI sequence will not really help over here because the microhemorrhages will look similar. So it's more of looking at the T2 fly sequence and looking at how the edema is going down. Another patient, 23-year-old female with acute onset right-sided facial droop, known lupus on prednisolone. Anything? So there's some kind of a hypodensity, isn't it, in the left basal ganglia? extending into the corona radiata. Normally, we'll call this as a acute infarct, like acute infarct in the left basal ganglia. But the clinical findings were not typical. MR imaging was done. So what we are seeing here is there's a lot of edema involving the left lentiform nucleus, and the edema is extending into the posterior limb of the internal capsule as well. Now diffusion, there's only a small focus of diffusion along the posterior aspect of the lentiform nucleus. Well, there's a mismatch. There's a lot of edema and only small region of diffusion, which is not typical for an acute infarct. Then SWI, we are seeing a lot of blooming, and the blooming has a very linear branching kind of a pattern. So it looks like a very vascular in nature rather than some lesion that has just bled. So it doesn't look like an acute infarct. So the concern was what it is. Is it an infection which has bled, or is it maybe like some unusual thrombosis of a deep venous system? Maybe some vein has thrombosed, causing this kind of a venous congestion and therefore the diffusion restriction. Venogram was done, really doesn't show much. I mean, there's no obvious thrombosis, but we can't be too certain about the deep venous system. So a CT venogram was done, which shows nice opacification of the internal cerebral vein, vein of Galen, straight sinus. So it's not a typical CVT that we would encounter. So patient only had some mild deficits on the right side. So not sure whether this is infection or something else. Patient was just kept in the ward. We didn't have post-contrast initially, so post-contrast was done 6 days later. So in the post-contrast study, nothing remarkable. There's no significant enhancement, but the diffusion and SW had significantly changed. Now we can see that there's much more diffusion restriction as compared to the earlier study, and a lot of blooming. So now, within 6 days, the lesion has rapidly changed. It has become much more larger with a lot of cytotoxic edema, which doesn't look like an infarct. So patient is on SLE on prednisolone. Can be an infection, opportunistic infection. Now, which infections would really show diffusion, blooming like this with internal hemorrhages? Not common, but the question is whether this could be a fungal infection. Patient was started on antibiotics, but not covered for fungal. Repeat imaging done after 6 days, 8 days. Edema had extended inferiorly. So now we can see that even lower down in the basal ganglia, the edema is there. There is diffusion restriction involving the posterior limb of the internal capsule. And what's remarkable is there's a focus of diffusion restriction in the lateral ventricular trigone. So that suggests that some kind of a necrotic material has gone within the lateral ventricle. This visually we see with infections. When there's pus and the pus extends within the lateral ventricle, we'll see this finding. And post-contrast had only shown minor enhancement. Now the question is, are we looking at some kind of a very aggressive infection, which pus going into the lateral ventricle? And should this patient be started on antifungals, or should the patient undergo biopsy? Now, imaging-wise, this looked like a very aggressive lesion. But in the MDT, we were told that the patient is quite fine. Patient is nicely sitting up. Apart from some minor deficits on the right side, patient is perfectly fine. So that is there was a lot of discordance between the clinical findings and the imaging findings, which made an aggressive infection to be less likely. CSF was shown. CSF showed more than 200 cells. So it was decided that because of there's a lot of discordance, we will hold on to the antifungals. We will repeat CSF. If CSF worsens, we'll start antifungals and do biopsy. If it becomes better, then it could be anyone. What would be the non-infective cause for this? It could be vasculitis. So vasculitis can have a similar appearance, very aggressive look, but the patient may not look very toxic. So repeat CSF was done, and the CSF cell count started going down. So then we realized that because of clinical radiological mismatch, CSF becoming better, this could be some atypical focal vasculitis that we are looking at. Patient was started on steroids. At the end of 2 months, repeat imaging showed significant regression in the size and edema of the lesion. So this is an atypical presentation of an focal vasculitis. This is my last case, a 26-year-old male found unconscious on the floor, persistent low GCS. Anyone? Any obvious abnormality here? So nothing remarkable. We may say that maybe there's a little bit of hypodensity in the centrum semiovale, but no edema, there's no hydrocephalus, there's no midline shift, nothing to explain the low sensorium. So MR imaging was done, which showed a lot of edema involving the centrum semiovale, and diffusion showed a lot of restricted diffusion, so some kind of a cytotoxic edema. So basically, white matter, cytotoxic edema, patient is having low sensorium. So basically some kind of a leukoencephalopathy, possibility of a toxic leukoencephalopathy was considered, but what toxin? Eventually we found that this patient is a cocaine abuser. So this is a cocaine-induced acute leukoencephalopathy. So what I have done is I have shown you some very classical cases like hypertense MCA sign due to flare mismatch, and I have shown you some atypical imaging findings which are a little difficult to identify in the initial go, but with collaboration between radiology and the clinical departments and better past history, we can come to a diagnosis. And I would like to thank you for your attention.